everybody. This is hopefully a refresher course for everybody on emergency contraception. I think I know everybody, but I'm Elise Pignata. I'm one of the fourth-year residents in the Women's Health Elective.
I'm Esmina, now Bayani, sorry for the confusion, also one of the fourth-year residents in a Women's Health AOC.
And Julie Johnston, faculty.
So I think everybody's done this, texted my name to that number to join the poll, and then you should all have a pre-test, and then we'll review that as a post-test at the end as well. So objectives of today, we're hoping that by the end of today, you'll understand the importance of emergency contraception. We want everyone to be able to describe what options are available here in the U.S. as well as locally in the community. We are going to provide evidence-based information about the efficacy, safety, and side effects of emergency contraception today. And we're hopeful that you'll all be able to understand the differences and the mechanism of action between the different methods available. So none of us have any disclosures for today. This is the pretest, so you all have a copy, and hopefully everyone's done it. If not, take a look at it now. So I'm going to start with the definition of emergency contraception. Basically, it's post-coital contraception. So it's contraception used to prevent pregnancy within 5 days of unprotected intercourse. It is important to note that it will not interrupt an established pregnancy. So it is different than abortive pills. It is not an abortion. And then when can it be used? So obviously there's cases when someone walks in and we all know it can be used. They've said they haven't used any sort of method at all. The condom breaks, an IUD has fallen out. But then other kind of periods when you might want to use it that are maybe not at the tip of your brain. If a person comes in and says that they've missed 3 or more days consecutively of their combined oral contraceptive pill, they're eligible for emergency contraception. With the progestin-only pill, the window is actually much smaller. So if they're outside of 3 hours, they're eligible. And then with the depot, so if they've been a total of more than 16 weeks from the last injection, that qualifies for emergency contraception.
So there are many reasons why we should learn about emergency contraception and provide information safely to our patients. We all know that nearly half of all U.S. pregnancies are unintended, meaning that they're either mistimed or unwanted altogether. We also know that women of low socioeconomic status, like our patients, have much higher rates of unintended pregnancy, about 5 times the rate of their highest SES counterparts. And finally, 2/3 of unplanned pregnancies are paid for by public insurance programs like Medicaid, whereas only 50% of overall births are. An interesting role for emergency contraception is for women who are either using contraception irregularly, inconsistently, or incorrectly. So this is a graph showing that in 2008 there were about 43 million women at risk for unintended pregnancy in the U.S. About 68% of them were using contraception consistently and correctly. And these women accounted for only 5% of unintended pregnancies. But the 18% of women who were using contraception inconsistently accounted for 41% of unintended pregnancies. And finally, the 14% of women who were either not using contraception or were taking gaps of more than a month were responsible for a majority of unintended pregnancies, 54%. So this is a reminder to us that even if we see a contraceptive method on a patient's medication list, we should be checking in consistently to see if they're using it properly, if they're using it consistently, otherwise they will be at high risk for unintended pregnancy. You never thought you would have to see this again, but we will review it for about 10 seconds. So to be brief, this is the menstrual cycle. Day 1 is the first day of menses. The first half of the menstrual cycle is the follicular phase. This is when FSH helps to grow a follicle in the ovary. Estrogen is then produced, and that triggers the production of the LH surge. The LH surge is what triggers ovulation when the egg is released from the ovary. So the period around the LH surge is intimately tied to ovulation, which is tied to fertility, so we're going to be talking about that a lot. This is a diagram showing an ideal 28-day menstrual cycle and where all of the methods that we're going to talk about today fit into this cycle. So day 1, again, is the first day of menses. Around day 12 to day 13, the LH surge happens. And about 12 hours later, the LH peak occurs, which triggers ovulation on day 14 in an ideal cycle. If sperm is present, fertilization will occur in the next 5 days, and then the fertilized egg will travel in the fallopian tubes, and in about the next 5 to 7 days will implant. After implantation, that's when pregnancy begins. This is a mainstream medical definition agreed upon by the FDA, ACOG, and the AMA. So you can see that all of the methods that we're going to talk about today happen before the beginning of pregnancy. And one more point. It's really important. This also helps us understand that when patients come to us for emergency contraception, we really should be trying to figure out where in their cycle they are, because that will help us guide which EC method would be the most effective for them.
So here's the first little quiz. Sally's one of your patients. She's 18. She comes into the office. She has a BMI of 25, and she tells you she had unprotected intercourse 2 days ago. She wants to know how she can prevent pregnancy and what her options include today. So A is Ella, B is Plan B, C is the ParaGard, and D is all of the above.
If you didn't join the poll, the Elise Banyan 802 is what you need to text to 22333.
All right, so it looks like a lot of people have voted here, and D is correct for all of the above. Okay, so this slide's basically a way to visualize the different methods and how effective they are. So going from top to bottom, top being the most effective and the bottom being the least. So the ParaGard Copper IUD is the most effective emergency contraception regardless of BMI. After that, there's 2 types of pills that a woman can take, Ella and Plan B. Ella being more effective than Plan B. And then lastly is the combined OCP method, the USP method, which is the least effective. So this is basically this next, yeah, see it. We can just flip it.
Go back. Try to go back.
Oh, there it was first.
Look at it really fast. There it was.
It was basically just a way to visualize what I showed you earlier. So we'll just continue on to the ParaGard.
Okay. Fair enough. So the copper IUD, or the ParaGard, is the most effective method of emergency contraception. It's 99.9% effective, and it's effective regardless of BMI. It can also serve as long-term contraception for 10 to 12 years. Across a systematic review of 42 studies, the ParaGard was found to be 99.9% effective. After it was inserted nearly 7,000 times after unprotected intercourse, only 6 pregnancies resulted. This is a reminder that ACOG does recommend that IUDs be suggested to adolescents. It is not contraindicated in nulliparous women. And it doesn't increase the risk of baseline STIs or pelvic inflammatory disease, as long as we do our due diligence and don't insert an IUD in a patient who's having active cervicitis. IUDs should be the first-line option for emergency contraception in any woman who's seeking EC and a long-term contraceptive method. regardless of her age, regardless of her parity status.
It was working.
It's okay.
Sorry. That worked too.
Oh.
What did we just do?
I think it's just like a minute. Okay, so this is the next quiz. What's the maximum period of time after unprotected intercourse that you can insert the ParaGard IUD?
Peer pressure.
Maybe we should cover this up until everyone answers.
They have the answers in front of them.
Yeah,
Yeah.
that's okay.
You can cheat.
It's called adult learning. It's okay. How do you know how many people?
You know, you just
Yeah.
go
Oh.
when you're ready,
I'll wait another minute. People are still.
making decisions.
All right. So most people actually got the right answer, even though it's not about getting the right answer. It's about learning. So ParaGard, you can use it within 5 days of unprotected intercourse. We shouldn't be using it more than 5 days after ovulation for its use as an emergency contraceptive method. The main mechanisms of action of the copper IUD are promoted by the local action of copper. So copper basically creates an unfriendly pregnancy environment. So it prevents fertilization by interfering with sperm viability and mobility. It prevents the development of eggs. And as a secondary mechanism, it also prevents implantation. Of note, that secondary mechanism is unique to the copper IUD, and it doesn't apply to the other EC methods that we're going to be talking about today. So ParaGard go ahead.
So you said after ovulation and not after unprotected sex. So if by my calculation, based on the patient remembers of their period, it seems like it may have been 5 days. This is not a good choice.
It's not, it wouldn't be useful as an emergency contraceptive method at that point. It might still work to prevent pregnancy, but then we're outside of EC.
Oh.
Be more likely to affect implantations at that point.
So I guess it would be involving like talking to your patient about if they understand that and if they would like to move forward with it. So the challenges associated with ParaGard is that it has to be placed by a trained clinician, and it must be removed if pregnancy is diagnosed. The cost can be high, but it is covered by insurance, and we're fortunate enough in this community to have health quarters if the patient is not insured. So we'll come. Sorry, just give it a minute. There it is.
So she's in your office, and you're all ready to do the ParaGard today for Sally. So what do you actually need to do today before inserting the ParaGard? A cervical and bimanual exam. B, pregnancy test. C, have negative chlamydia and gonorrhea results. D, all of the above. So dynamic. All right, so it looks like we're kind of split here. The correct answer actually is A. The only thing that you are required to do is a cervical and bimanual exam. You want to see the position of the uterus, and you want to ensure that there is no evidence of cervicitis. Pregnancy tests could be indicated if your relative, let's say Sally comes in and she says, you know, my last menstrual period was 2 weeks ago. I had one episode of unprotected sex 2 days ago. you're relatively sure you're sure she's not pregnant today, and that she falls within the realm of using a ParaGard. So it's not necessarily indicated to do a pregnancy test today. You don't actually need negative chlamydia and gonorrhea results to put the ParaGard in. Obviously, she's had unprotected intercourse. You should collect a chlamydia and gonorrhea. But if you don't see evidence of cervicitis, you can go ahead and put the ParaGard in today. And then one more thing to note is sometimes doing a pregnancy test in the office could backfire. If it is negative and she knows it's negative, she might think that she's not pregnant. She doesn't need emergency contraception too. So here's some billing tips. We're going to start with what you do, and most of us know this. This is just a review. For both the Mirena and the ParaGard, we all know that we need to put in a procedure code and a diagnosis code for both of those devices. And then for all patients, whether they have Mass Health or private insurance, the ParaGard device is billed through the clinic. So during that visit, you also need to put the supply code for the ParaGard. And just as a side note for the Mirena, yep.
So just to back up on the presumption that everyone knows this, I'm going to stand outside the presumption, because it seems like we always have, I've heard the discussion oftentimes that you only need to put a procedure code if you're doing a procedure, or maybe you put a diagnosis code. But so for any IUD, you need to put a procedure code.
IUD insertion procedure code.
Diagnosis code.
Yes.
Well, the diagnosis code is like IUD insertion, the diagnosis, and here at Greater Lawrence we use the procedure only separate code, which is level 2, which is then removed, which doesn't get billed. So in essence, you need the diagnosis of IUD insertion and the procedure of the IUD insertion. Is that totally okay?
So I fill out an order and something in the assessment and plan? Meaning the procedure code and the diagnosis drop-down menu that says
Procedure. If you had an extensive discussion, like she came in today and said, oh my gosh, I had unprotected sex, what can I do? And you go through all of her options, she didn't come in and say, I want a ParaGard, then you would use a level 3. You
with
could
a modifier 25.
With a modifier 25 for the IUD insertion. Yes.
And is the doctor responsible for putting in the supply code? Because I'm
You
not
are
sure I've
responsible
ever
for
done that.
everything you do.
Joe here?
We are going to make
Sandra?
we're going to make a order set for this to make it easier for you. Julie and I started talking about this. So you know the order sets that we have for SPD or STI ordering. You click that, it has the whole list of all the STI tests. Or the one for
Diabetes.
cervical screening, the cancer screening drop order set. We're going to create an order set for this because people often forget these little things. So
Currently, they're all located in the medical assistant order set. That's where all
But if
of
you
them
type
are.
in
Which all of us look
ParaGard,
at.
it's right there, and it's the one with the J. Is the
Otherwise, the clinic eats $700 every time it's not.
Actually, I remember I do that every time.
Contraception as a diagnosis, or does it have to be insertion of IUD?
Usually, you can do both. The IUD insertion is more specific. It's better to be more specific.
the other thing that's helpful, Julie, is that when people order Mirena, they put it on the med list because they order it from the pharmacy.
Yes.
It's helpful if people also put ParaGard on the med list, but put it in historical because it's not going to get filled by the pharmacy.
Yes.
That way it's on their medication list so that if somebody sees them later,
That's a good point.
they know that it's there. It's just helpful.
Yeah.
But you have to do it historical because if the pharmacy gets it, they're going to go, what?
And then the Mirena, which we're not using for emergency contraception in this moment, but we'll talk about that later. For people with private insurance, you need to bill that device as well through the clinic. That's not to the pharmacy. For all the Mass Health users, we send that to the pharmacy. It's billed at the pharmacy. They clear it. That's how it's billed.
And a message that you'll get if it's a private insurer and you kind of knee-jerk send it to the pharmacy, because that's what we always do, it'll say this is a non-pharmacy benefit, which means it's a clinic benefit, and your MA can reconfirm that with their insurance. But you'll get this message and you'll think, oh my gosh, they can't have it. It just means that you need to use the clinic stock for the non-pharmacy benefit notes.
And lastly, if something goes wrong, if you touch the device and you're not sterile, you drop it, you open the package and the os is too stenotic to insert it, talk to the MA at your site who is in charge of the IUD stock, because they can call and get reimbursed for it possibly. Don't just think that we're going to have to eat the cost.
So if you're here at Haverhill Street, that would be Rosara, my MA, and your team. I see it.
Good one. Yeah. Okay, so Maria's 24. She's coming in because she also does not desire pregnancy. She had unprotected intercourse last night. She's healthy, but she's obese with a BMI of 30 and a weight of 180 pounds. She doesn't have time for a procedure today, but she would like some EC. What do you recommend for her? Yeah, good job. So basically, as we kind of already touched upon earlier, and everyone indicated that they're aware of, the different methods are efficacious depending on BMI. So copper IUD, regardless of BMI, this is the most efficacious form. However, she's telling you she doesn't have time for a procedure, so Ella would be your next option. It's important to note that Ella is not recommended if you're either over 195 pounds or BMI of over 35. And what that means is it's less effective. If that's your only option and someone comes in, still give it to them. But you can do the appropriate counseling, but this is not as an effective method for them because of their BMI. Sorry.
What's the failure rate?
That's the next
For
slide.
using it over BMI?
We're getting there.
Oh.
Good question.
It's a good lead-in. And then Plan B is not recommended if either 165 pounds or BMI of 30 or over. And it's actually no more effective than placebo for a BMI of 35 or over, which is Nina's going to discuss.
Is that a change? Because I feel like I remember Julie's talk a couple years ago that it was BMI of 28, it was no better than placebo, which really scared me more than what this says.
There's more data at this point.
So that was a good lead-in into what the actual effectiveness is. So this is a study that was published in Contraception in 2011, and it directly compared users of Ella, Ulipristal acetate, which is the graph on the left, versus the bars on the right, which is Plan B or Levonorgestrel. So basically what it showed was for BMIs less than 25, they're actually pretty comparable. For BMIs of 25 to 29, overweight women, Levonorgestrel's failure rate is about 3%, whereas for Ella it's 1 to 1.5%. And then as you get to obese, so BMI greater than or equal to 30, Levonorgestrel's failure rate is about 6%. So not only is that this 2 to 3 times what it is for non-obese women, it is actually approaching the failure rate of women who use no emergency contraception, which is about 6 to 8%. So something important to remember when you're counseling your patients. And Ella actually holds pretty efficacious regardless of BMI, although its failure rate does go up a little bit. Again, like Elise said, this doesn't mean you can't give it or it's not safe. You definitely should, regardless if these are your only options, but you should warn your patient that it's probably less effective. Does this answer both of your questions? Okay. So, there's another question. So, what's the maximum period of time after unprotected intercourse that Ella, Ulipristal acetate, is still effective? So most people have the right answer. So Ella is a 30 milligram single dose tablet. It can be taken like ParaGard within 120 hours or 5 days of unprotected intercourse. The main mechanism of action is that it's a progestin mimic, and it delays or inhibits ovulation and prevents follicular rupture. It is 97 to 99% effective across BMI categories, like we saw on the last slide. There have been some studies showing that it's the same efficacy day 1 as day 5. So this just shows that Ella delays 100% of ovulation before the LH surge and 79% of ovulation before the LH peak. So this is why we think that Ella is more effective than Plan B, is because it has that little extra window to work in where Plan B doesn't, between the LH surge and the LH peak. And it also prevents follicular rupture even when Plan B doesn't. The challenges associated with Ella are that it's prescription only, not over the counter. It's only found in some pharmacies. So all Greater Lawrence pharmacies carry Ella all the time. So the best bet is to send a patient there. If a patient really can't go to a Greater Lawrence pharmacy and would like to use another pharmacy, you need to call ahead and make sure they actually have it. I wish I could give you a list today of all the pharmacies that carry it, but formularies are constantly changing, so there isn't a stable list. Ella is contraindicated in breastfeeding, so women need to wait a full week before they breastfeed. And the cost is about $30 to $50 out of pocket or $60 online, but it is covered by insurance.
Do you guys have an idea of why a better emergency contraception option is less available?
The manufacturer changed a couple of years ago, and people haven't re-entered contracts with the new manufacturer, so it was like a kink in the chain. And unfortunately, I've had what has happened is I've sent a script to a pharmacy that I thought would have it. They didn't have it, and they told the patient to come back 2 weeks later. So with no feedback to us. So really, you can't rely on the pharmacy contacting you and asking for substitution. So oftentimes we get the question, a patient comes in and they want a refill of their emergency contraception, which is totally fair, but that's a really great opportunity to say, this emergency contraceptive is good for one time, but is there something that you would like to talk about as an ongoing method of contraception so you won't have to keep on coming back? It is safe to have a patient take it more often. You don't need to take Levonorgestrel or Plan B more than 5 days apart. So if they have unprotected sex, 2 days later they have it again. They don't have to take another pill within that 5-day window. For Ella, it looks like because the washout period is about 5 to 7 days, that you don't need to take another pill of Ella within 7 days. And you shouldn't take Ella, which is a progesterone receptor blocker, and a progesterone Plan B together within 7 days, or they can cancel each other out. There we go. So Maria gets her Ella, and she wants to restart her Defo. Can you give her Defo shots right there in the office that day? Something about always picking the longest answer, I don't know. So, yes, all of a sudden, March of 2015, this became very controversial. So I've been, encouraging the quick start. You guys we have the quick start there, maybe we can pass around for people to look at if you're unfamiliar. And in general, we want to address contraceptive needs when we have our opportunity. March of 2015, the FDA put a label on Ella that you shouldn't use any hormonal contraception within 5 days of Ella. This was based on one study of desogestrel, which is a progesterone-only pill, which is not available in the United States, which showed that it reduced the effectiveness of Ella. So for cycles where people took Ella and no contraception, it blocked ovulation or prevented pregnancy at least 45% of the time. But if it, or they, no, they, I'm sorry, it prevented pregnancy all but 3% of the time. For when they took Ella and they took the Desogestrel, there was a 45% chance of ovulation within 5 days, which doesn't make them get the emergency contraception protection that they desired and you wanted to give them. So what do? We have one study, Desogestrel, not available here. It's a very strong type of progesterone, and it might be much different of mechanism of action than like the Mirena IUD or the Depo-Provera. So currently, we have no data on the available methods that we have here in the United States. We don't have any data on combined contraceptive methods in Ella. So right now, there's this FDA label, but I think it's a conversation that you want to have with your patients, because some people, they're going off to college, they're heading to the DR, and this is their one opportunity while they're in your office to get an ongoing method of contraception. So a lot of people in the reproductive health community are still quick starting people. The selective practice recommendations for contraceptive use still maintains that you need a 14-day backup for Ella, so 7 days for it to wash out, and then another 7 days for that method to have enough in your system. So it's hard to know what to do. It's definitely hard to know. I have this conversation with my patients, and some of them elect to wait, and some of them say, this is really important to me that I get the defo today. So hopefully we'll have more studies soon with methods that we have available here, so we can give better advice.
So Maria, she calls you at the office. She says she has a thin friend who had unprotected sex last night. She remembers you mentioning a pill that's over the counter when she came in, but her friend doesn't have time to go to the office and is not your patient. So her friend wants to know, can she get the pill you're talking about from the pharmacy? Is it easily available in pharmacies in the area? So your answer to Maria is yes. It's stocked in all pharmacies and accessible without a prescription. And we are referring to Plan B right here. So it's important to note, to educate our patients and that we know as well, Plan B is available over the counter at all pharmacies, no age restrictions, no gender restrictions. Here in our pharmacy, it's $19. I'm sorry, it's $30 without a prescription if your patients just come in and buy it on their own. So a confusing point about Plan B is that, and this is why we need to make sure our patients know this, on the back of some of the labels, it says that this is recommended for women of 18 years or older. So that's just a use recommendation. It's not a restriction. Anyone can still buy it in the pharmacy, no age, no gender restriction. And then the other thing to note is it comes in two forms. It comes in this one-dose form, which is 1.5 milligrams once, that's it. And then the other form is 0.75 milligrams, 2 pills, 12 hours apart. That second formulation with the 2 pills at times is kept behind the pharmacy, and that they may require a prescription for. So that's confusing as well for patients and pharmacies.
Why do they have the 17-year-old, like not restriction, but use recommendation? Is it like a political thing, or?
I actually
is
don't know.
there-
16-year-olds don't have sex.
Why would you?
Is that one not coming up either? Oh, well, I'll just talk about it. It's fine. That's where it's just randomly. So this one basically just shows like all the different boxes. Oh, sorry. Go ahead, Nick.
Is that the same in all states, the age 10 or 18
Yeah.
nationwide?
Yes.
Yeah. Lots of these articles about this.
So sorry this isn't coming out. It basically just shows all the different boxes available. So basically another confusing aspect of this is we know that you can use it within 5 days, 120 hours. That's what we know. However, The longer a woman waits from when she had unprotected intercourse to when she takes it, the less efficacious it is. And that's because it basically works before the LH surge. So you want to get her in that time period before the LH surge, and you're more likely to do that if you do it right after she's had an episode of unprotected intercourse. You might see that there's a couple different studies out there. There's a WHO analysis which says it's effective up to 96 hours, but we know it's 5 days, in your brain 5 days. And the failure rate at best is 1% if taken within 12 hours, and then 3 to 4% within 72 hours. So it's just important to educate your patients that it's less efficacious the longer they wait from unprotected intercourse. And then this is just a slide.
Can I say something? On your handout it says 72 hours. That's the label use, so that's why it's on there. And it is the most efficacious in that time period. If it is getting to 4 to 5 days, you can still give it, but less effectively. So that's why we put 72 hours on the handout.
Yeah, you might have to talk to your pharmacist.
Oh, they won't
I don't
prescribe it.
remember, it's like, I wrote for 5, and then the pharmacy called me and said that was wrong.
We
We
had
had
it.
to try to clarify it with them, but you never know when there's going to be
Exactly.
a pharmacy resident, a new pharmacist, you're prescribing to Walgreens.
Right. We have an automatic label that pops up here that says take as soon as possible, but maybe given a
Right, I know we try to do that, but, you know, just be secure in your knowledge when the pharmacy calls you.
Right. And this is just a visualization that Plan B works before the LH surge, and then once you get there, it's not really very effective at all. So that's why it's important, A, counsel patients to take it right away, and B, even kind of take a good history and try and figure out where they are in their cycle.
So Maria says that she had some headaches after she took Ella, and she wants to know if her friend will feel like this after taking Plan B. So what are the common side effects of both of these emergency contraceptive pills? Yes, so it is D, all of the above, also another test-taking strategy. Patients can experience nausea, headaches, irregular bleeding, so they are likely to have spotting the earlier they take it in their cycle. Menses can be expected usually about a week early after taking Plan B or Ella. They can also have some breast tenderness, some abdominal pain, but all symptoms should resolve within 24 hours. After taking Plan B, she is interested in starting an oral contraceptive pill. She wants to know when she can start this. Tomorrow, in 7 days, or after her next menses.
I don't think
It's not working.
It says I can't vote anymore.
Oh, yeah. Exactly.
Okay, show of hands. Who says tomorrow? Okay. Who says in 7 days while using barrier protection? Who says after her next menses? Who says nothing? Everyone. Okay.
Have you read all the options before you started?
So using Quick Start, which there's a couple of copies circulating, she should start OCPs immediately the following day. So starting contraception after taking Plan B is much less controversial than after taking Ella. So according to the Quick Start algorithm, she can start it right away, but she does need to use some sort of backup method for 7 days, so either abstaining or using barrier protection.
And then we just wanted to go over this method so you understand that it exists. Here it should not be used. We have better methods. So this is more for like resource limited areas. There's nothing else available. So this is a USP method. And it's basically where a woman can take multiple OCPs over 12 hours. She should take within 72 hours after the unprotected intercourse. At best, the failure rate is 2%, and there are significant side effects, significant nausea, vomiting. And then it's important to note that it's different with each type of pill. So you'd have to look up what pill she's on, and then how many pills she'd have to take now and in 12 hours.
It's usually somewhere between 4 and 6 pills. So you can imagine how that would make someone feel.
Yeah.
Many of us work outside the country. It's very part of our life. We work in the 50s, 35s, we can get by with 21 or is there anyone you should point to try to get some local?
So it's going to be, you have to look up, there's charts for every different pill type, so it's going to be more pills for a 20 microgram at a time than like a 35.
And then other issues, pregnancy tests. So as we kind of talked about earlier, you don't need to do a pregnancy test before giving EC, but if you've done a good history and you're sure she's not pregnant. But you should counsel her that if she doesn't get her period within 2 to 3 weeks of taking emergency contraception, she needs to take a pregnancy test. And then if the pregnancy test is positive, an IUD must be removed. Plan B and Ella have no evidence of causing birth defects, spontaneous abortions, or ectopic pregnancies, so they do not disrupt an established pregnancy.
And just real quickly, for some late breaking news, in the June issue of Contraception is an article that discussed the possibility of using Mirena and Plan B on the same day, and they showed that it was almost as efficacious as using copper IUD for emergency contraception. So failure rate of 0.9%, which is very good. So we have one published study in this area. So I think we're going to be having more data soon. So currently, Mirena is not FDA labeled for emergency contraception. I would say there's not quite enough evidence to start boldly going that direction, but hopefully soon that'll be another option for someone who wants an IUD but isn't happy, perhaps with the side effects of ParaGard.
Okay. So it's time to review our post-test now. So true or false, the ParaGard, Plan B, and Ella are all options for emergency contraception.
True.
Yeah! Plan B is available over the counter without a prescription, while Ella is not. True or false? True. Great. You must be 18 or older to buy Plan B over the counter.
False.
Great. Ella and Plan B are equally effective at preventing pregnancy in women with a BMI over 30.
False.
Good. An emergency contraception causes abortions.
False.
Yes. Love it. Now you're up.
Okay. So I think you guys got the take-home points pretty well, but just to recap, the copper IUD is the most effective method of emergency contraception, followed by Ella, followed by Plan B. Remembering that efficacy hierarchy is particularly important in women who've had sex more than 72 hours ago, who are overweight or obese. Ella is more effective than Plan B because it works after the LH surge has begun, and all emergency contraceptive methods are contraceptives. These are just some additional resources if you're looking for more information. Bedsider.org, American Society for EC, and nottolate.com. That last website has a really good chart if you need to use the USP method in other countries. There are some really great handouts to give to your patients in both English and Spanish available on Reproductive Health Access Project, describing all the different options for your patients, and then the ARHP also has some information. So we have some time for questions, and if anything comes up about any women's health issue, you can always email the Women's Health AOC listserv that you can find pretty easily in Outlook. Those are our references. So we would be happy to take any questions.
I just want to clarify the ParaGard thing. So it sounds like the take-home point is you need to say if you're within 19 days of your first day of bleeding, then you can use ParaGard as an emergency contraceptive. You have to use it within 5 days of ovulation for it to be an emergency contraceptive. And if you're between 19 and 28 days, then it might still work, but you might be causing abortion. It's kind of the contradicting.
Right. So really, you shouldn't be doing it after ovulation, like after ovulation.
After ovulation at all.
Right. So
For those, for 5 days
right.
between ovulation.
Yeah. So you can use it very close to when, but it's not recommended.
So really, like first 2 weeks is like
Yeah.
very good option.
And if you're unsure, I mean, you can do it. It's not going to hurt the patient. It's just a longer conversation.
Yeah.
And like with the definition of EC working before, implantation and that.
Is it possible to get a copy of your PowerPoint?
Yeah.
Great. So you have a handout. I'm sure you've all seen it. So have a good day. Thank you.